Yeah, so the topic I was given was strategies to prolong latency in patients presenting with preterm premature rupture of membranes. I thought it was not a very easy topic to do because the number of interventions out there to try and prolong latency is in fact quite limited. But as Pilisa said, it is a huge problem. Worldwide data indicates that almost 3% of all pregnancies are complicated by pre-prom. And this is associated with almost 30 to 40%, if not more, of preterm births. I mean, I mean, it's always pertinent to ask ourselves what happens if we don't intervene. Again, the median latency after pre-prom is around 7 days, and this is inversely proportional to the gestational age at which pre-prom happens. So somebody has ruptured membranes at 25 weeks, they're likely to have a higher latency than somebody who has the same at say 34 weeks, which is just a fact of nature. But even saying that even in pre-viable pre-proms, almost 40 to 50% of patients will give birth within the first week, and 8 out of 10 within 5 weeks after membrane rupture. So again, as Pilisa said, even prolonging latency by a few weeks may have a significant impact for the neonate and for that family as a whole, because the complications of prematurity and that's such a difficult thing to tackle, and anything we can do to change this will make a big impact and make a big difference for our patients. I mean, the only thing which definitively improves latency is when the leakage seals off on its own, and the amniotic fluid volume normalizes. However, this happens spontaneously. It's not very well understood, and this is the most important factor associated with favorable outcomes. I mean, any talk around increasing latency will be incomplete if we don't go into the risks of prolonged latency. And as it's fairly self-evident that the longer the latency, there's a higher risk of infection, higher risk of abruption, and the duration of latency is also linked to neurodevelopmental impairment. But these risks tend to decrease with the increasing gestational age at birth, and that's why we try and push towards look at factors to prolong latency. Again, any talk around latency will be incomplete without mentioning when we should intervene to shorten latency, and it is obviously if there is fetal compromise, signs of infection, these are the commonest indications to shorten latency. And looking at the recommendation from the RCOG around diagnosing clinical infection, so it's a combination of clinical assessment parameters in combination with CRP and white cell count, along with CTGs that will help make this decision. Again, there is a lot of emphasis on stating that because of the high false positive rates around individual parameters, if it doesn't really correlate with diagnosis, perhaps repeat the test before we actually intervene to shorten latency. Now, before we can look at interventions to prolong latency, the currently established factors or accepted factors which impact latency are cervical length, presence of cervical funneling, amniotic fluid volume. In fact, oligohydramnios is one of the most significant factors associated with the shortened latency ratio. Gestational age and infection. If you look at literature, since around the early 90s, there's a lot of data around home management of PROM. In the UK, we do use home management of PROM. So after somebody is diagnosed with a preterm premature rupture of membranes, patients are admitted started on antibiotics, consideration for steroids given, and if things stabilize, people are advised to go home and attend the hospital once or twice a week for monitoring with CTG, scans, clinical monitoring, and bloods to look for signs of infection. But I mean, the data often gives us we can't draw any conclusions from this, because this is a self-selected population who undergo home management. Because as we all know, the risk of going into preterm labor is maximum around the time of diagnosis. So those patients would have been in hospital. After they stabilize, they would have been discharged home, and this is possibly the reason for this uh, uh, data suggesting that home management helps with prolonging latency. So yeah, it may not be of clinical significance, but I just wanted to put it out there because that's what the data had shown. So if you're going to target factors which impact latency and to improve latency, as the previous slide alluded to, the things available around, I mean, the factors which impact latency are: one is cervical length. That is not really amenable to intervention after somebody comes in with pre-prom, because putting in a stitch after pre-prom is contraindicated. Second issue again relates to the cervix and diagnosis of presence of cervical funneling at the time of diagnosis. Again, there's nothing you can do about it after somebody comes with rupture of membranes. Third thing which impact latency is amniotic fluid volume. Yes, amniotic fluid volume, there are interventions available, and we'll go through that in the subsequent slide, but it is of there's a doubtful evidence base behind use of things like amnio infusion. Gestational age at pre-prom, again, there's nothing you can do after somebody comes to us with pre-prom. Yes, it is. This is interventions are available in a subsequent pregnancy, which would potentially prolong the gestation at which pre-prom happens. And the mainstay of carbon management options relate to preventing infection. So I was hoping to go through these in the next few slides. Coming on to amnio infusion, reviewing the Cochrane database on pregnancy and childbirth trials register. There are some randomized trials available around comparing amnio infusion with no amnio infusion in women with pre-prom. Results are definitely encouraging, but the data is fairly sparse, and the methodological robustness is open to question. So no definite conclusions could be drawn on use of amnio infusion. So yes, further evidence is definitely needed before we can use amnio infusion in routine clinical practice. Again, it's fairly logical. If there's more fluid around the baby, there's decreased risk of cord compression, decreased risk of postural abnormalities, decreased risk of pulmonary hyperplasia, and the dilutional effect also tends to decrease the risk of intrauterine infection. The Cochrane review again suggests that amnio infusion is associated with improved fetal umbilical artery pH at delivery, reduced variable decelerations in labor, and improvement in mortality and neonatal morbidity, and decreased risk of puerperal sepsis in the mother. Coming on to the mainstay of interventions, these are all related to infection. There is good evidence base in use of antibiotics in pre-prom. And the basis for this is microbial infection of the amniotic cavity. So we can detect this by culture in around 30% of affected patients, and employing a combination of culture and molecular techniques, the detection rates are around 50%. There are several studies set mainly in Korea and the Far East, where they've looked at serial amniocentesis and culturing the fluid from patients with pre-prom, and they found that by the time somebody with pre-prom goes into preterm labor, the infection rates go up to almost more than 75%. And so the infection plays a significant role both in genesis of PPROM and in the onset of preterm labor. Again, I remember being told off by my professor as a first year postgraduate student. I think Dr. Joshi was part of the audience when I was being told off, as he was my senior at St. John's for doing a digital examination. And we all drill into our juniors to say not to perform digital examinations, but to limit ourselves to speculum to diagnose preterm labor for fear of introducing infection. In the UK, the antibiotic of choice is erythromycin, and it's given 4 times a day for 10 days or till the woman is in established labor, whichever is sooner. And this is enshrined in NICE Guideline 25. In the US, their practice is slightly different. They use ampicillin and erythromycin for the first 48 hours, followed by oral amoxicillin and erythromycin till delivery. The only consensus is to avoid co-amoxiclav because of the increased risk of neonatal necrotizing enterocolitis. Um, Again, so there is a fairly robust Korean data which have shown that. So this is based on actual culture of the amniotic fluid. So they found that anaerobes and genital mycoplasmas are frequently involved in the infections, and none of the commonly used antibiotic regimes tend to cover these organisms. So they've been using a combination of ceftriaxone, clarithromycin, and metronidazole. Their data suggests they're achieving prolonged latency, reducing histologically proven chorioamnitis, with a tend towards improving neonatal outcomes in patients with preterm PROM. I just wanted to highlight the regime that they're using, and it involves ceftriaxone 1 gram IV every 24 hours, followed by clarithromycin 500 milligram oral every 12 hours, and they use IV metronidazole 500 milligrams 8-hourly. And again, the duration of antibiotic treatment is different in the Korean regime. So they are given until the patient delivered, or if there is no evidence of continuing amniotic fluid leakage. But they tend to limit use of metronidazole for maximum of 4 weeks. Again, this brings us to the question of how long should we give antibiotics for? Because if you look at it logically, if our aim of it antibiotic therapy is to prevent infection, then it would make sense to use a prolonged regime. However, in the UK, the use is limited to 10 days. And in the UK, our practice is to push gestational age as close to 37 weeks as possible before you intervene to start labor. In the US, their guidelines still says push to 34 weeks and then offer induction of labor. In the US, they tend to continue antibiotics till delivery, which is around 34 weeks. In Korea, again, their practice has been to administer till delivery is occurred, but stopping the metronidazole for after 4-week duration. The Korean data suggests that they're able to push latency by a few weeks by kind of employing this different antibiotic regime. Again, the last thing I wanted to touch upon was tocolysis. It may prolong pregnancy, but there's increased risk of chorioamnitis without significant maternal or neonatal benefit. Most of the studies have looked at tocolysis in isolation with use of antibiotics and steroids not being really evaluated adequately in the studies. If you look at, again, Cochrane review, use of tocolysis increases latency by around 3 days or so. But it is associated with an increased risk of APGAR score of less than 7 at 5 minutes, and an increased need for ventilatory support for the neonate. And there is fairly robust data to say that there is increased risk of chorioamnitis with use of tocolysis. So the conclusion from the Cochrane review is that there's insufficient evidence to support tocolysis, and it is associated with chorioamnitis without significant benefits to the neonate. So coming to my last slide, take-home message, very few interventions with the robust evidence base to increase latency. Prevention is better than cure. So in UK practice, if somebody has PPROM, in the subsequent pregnancies, we offer cervical length scans between 16 and 24 weeks with an offer of a suture if there are concerns on cervical length scanning. Individual management protocols are potentially effective in prolonging PROM, but the evidence base is not strong enough uh, 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 to support general use. So this is based on intense a regime of interventions with amniocentesis, trying to isolate organisms, tailoring an antibiotic regime to try and target those particular organisms, and this employed in combination with amnio infusion has been known to prolong the pregnancy and improve outcomes, but the data to support this is not robust enough to support general use. So yes, this may be applicable in a very select setting. And with that, I was hoping to conclude this presentation.